Hello friends, this is Dr. Abhinav Prakash and welcome to Abhinav Eye Coach. Today I am going to show you a surgical video of phacoemulsification performed by me for soft cataract. As this is a routine case performed by me, and we all assume that soft cataracts are very easy to perform, but there are some difficulties we all face during such kind of surgeries, and there are a lot of chances that we may get stuck at some steps. So there are some easy tips by me how to perform these cases easily and smoothly and effortlessly. So here we are performing this case in topical anesthesia. So we have injected preservative free intracameral lignocaine and we have filled the anterior chamber with dispersive viscoelastic. We coat the cornea with viscoelastic to enhance the view. So I prefer to perform capsulorhexis with needle only. It's your preference. You may choose capsulorhexis forceps, but I use cystotome to perform the capsulorhexis. In whatever way it is convenient to you, you can prefer that method. So I find it more controlled and more uniform and repeatable to do with the cystotome, and I consistently get very good results and a perfect circular rhexis and adequate size rhexis every time. So see, the flap is raised and try to keep the flap overlapped all the time. Don't let the flap raised at any of the steps in capsulorhexis. As long as the flap remains flat, the capsulorhexis will remain controlled and it will not run out. So we are making a perfect square shaped main port with the help of 2.4 millimeter keratome, and such kind of incision is very strong and self-sealing. So the square shaped main port is made. So here we are performing the hydrodissection. We saw the fluid wave, posterior fluid wave, and little bit more we perform it, and the nucleus is prolapsed. My preferred technique, flip and chop. So in flip and chop, we try to prolapse the nucleus out of the capsular bag, and now I fill the viscoelastic behind the nucleus and once in front of the nucleus to protect the endothelium. So nucleus is almost vertically standing. So this is, we buzz the phaco probe into the core of the nucleus in the center, and chopper goes behind, and we just bring the two instruments close to each other and squeeze the nucleus in between. As it is a soft cataract, there is a cheese wiring, otherwise it would have been cracked into two pieces, and this is very safe and very convenient method to chop the nucleus. So the nucleus is chopped, and as this is very soft, the nucleus is emulsified very easily. In such cases, in soft nucleus, try to do phacoemulsification with the handpiece very carefully as there are high chances, if you feel the nucleus is coming very easily into the phacoprobe, there are very high chances that you can break the posterior capsule. So it should be very controlled. Sometimes there is a urge to eat the nucleus, phacoemulsify the nucleus as soon as possible, as you feel this is a soft nucleus and it is coming very easily. But in such an attempt, the posterior capsule brings to the and touches the phaco-tip very easily and very often. So this is the first tip you should take care of. And we are performing the irrigation and aspiration of cortical material and nucleus plate with the help of coaxial irrigation aspiration. So just trying to loosen the soft epinuclear plate with little bit of gentle BSS and hydration of in between the cortex and the anterior capsular rhexis margin. So this will loosen up the cortex, and we don't need much efforts to irrigate, to aspirate the cortex. And care must be taken that while aspirating the cortex, just keep watch over the anterior capsular margin. There are very high chances that you can pull the anterior capsular rhexis margin, and it will lead to the zonular dialysis. So I have seen in my experience there are very high chances of pulling the rhexis margin. So after loosening the cortex with the BSS and little bit of hydration, the cortex is easily pulled out, and you can see there are not much efforts I am putting while doing this irrigation and aspiration. So the posterior capsule is clean. I am doing little bit of polishing from the equator, from the posterior capsule, from the anterior capsular margins, under the anterior capsular rhexis margins. So all these fibers which are not visible in this screen because of not very high resolution, all those fibers are very easily visible in the while you are doing the surgery in the microscope, in the retro illumination. So this subincisional cortex and subincisional fibers should be double checked, so that you should not leave any kind of cortical material behind that can lead to post-operative inflammation and raised IOP. So the cortical cleanup should be very gentle and very should be done very patiently. They should not be hurry, and the port of the coaxial irrigation aspiration port especially should be always visible. It should not go away from your eye, as it can catch the posterior capsule while doing irrigation and aspiration. And most of the posterior capsular breaks are occurred during the irrigation and aspiration. So here I am loading a single piece acrylic lens into the cartridge. The haptics are placed over the optics and near the entry of the cartridge port. So I am balancing the globe with the dialer from the side port, and very gently and in a very controlled manner the lens is injected. The first leading haptic directly lands up into the bag, and the trailing haptic is dialed at the optic haptic junction in the bag below the anterior capsular margin. So here the bag is placed, the lens is placed into the bag, and the visco is still there in the bag and anterior chamber. Before doing that, as the eye is inflated with the viscoelastic, here I am It's my way that up to one diopter I neutralize the astigmatism that is with the limbal relaxing incision. So against the rule, astigmatism is neutralized with limbal relaxing incision up to 3 to 4 clock hours. We can perform the LRI, and it is really very helpful for the patient post-operatively. So this viscoelastic removal, when we finish the case, we all assume that it is not an important step, or we don't pay much attention to remove viscoelastic thoroughly. So viscoelastic removal is done most patiently. The viscoelastic OVD is removed from the angles, as the dispersive are more difficult to be removed after the surgery. So all the angles are swept, all the anterior chamber is swept. It may take 2 minutes, 3 minutes extra, but take your time, and you should also go behind the IOL to remove the viscoelastic behind the IOL. So you have to lift the IOL by putting your probe absolutely horizontal to the floor, to the horizontal plane, parallel to the horizontal plane, and just this is the practice you will learn with the time. Just go to the edge of the optic and flip it above by doing this maneuver. Just tilt your IA handpiece horizontally parallel to the floor. It will automatically lift the optic, and you can go behind the IOL to remove the viscoelastic. So viscoelastic removal is done thoroughly. As you can see, there is a one more small shadow of the IOL. This is a Adolph modified extended depth of focus lens, and the Purkinje images are coinciding with the visual axis. Purkinje images are the 3 lights at the center of the lens should coincide with the 3 lights in the center of the cornea. They should coincide, and this is very important in getting the perfect results for trifocal extended depth of focus. These kind of lenses results are very much proportionate whether you are placing these Purkinje images. These Purkinje images should overlap each other. The patient will see 3-dimensional and very perfect vision, that is continuous range of vision. So I am trying to centralize the lens, and here the surgery is done beautifully, and hydrating the main port. Don't over hydrate the main port, just hydrate the roof of the main port, that's it. So our surgery is done. I have checked the IOP with my fingertip, and it should be normal. It should not be very high, and it should be normal IOP. It should not be very tight and hard. So thanks for watching, and I appreciate your patience. Thank you very much.